This conference will now be recorded.
Okay, so welcome all of you to the class. So Group B Streptococcus, like not a very big guideline, but people find it difficult and confusing. So I have got requests to take class. So now coming to it, so like Group B, Lensfield, Group B beta hemolytic Streptococcus infection. It is the most frequent cause for early onset neonatal infection. Okay, because of that we are worried about. Now GBS carriage, it do have a, it varies, its occurrence among the racial groups. Like it is highest in black African ancestry, and it is lowest in South Asian ancestry. Okay, apart from this, like it can be a part of bowel flora, and it can be a part of bowel flora in 20 to 40% of the adult. That is called as colonization, and the people are called as carrier. So you might have read in the guideline that woman is a carrier, or there is a carriage of GBS. So these are the people. Okay, so and the pregnant woman, if there is like there is no evidence that carriage rate is affected by pregnancy. So basically it is it is there as a bowel flora, and 20 to 40% of the patient. And so this number would be important for you. You may be asked in your any of the SBAs. Okay, now in UK, universal bacteriological screening is not recommended. Okay, this is the not same in all other part of the countries, but as we are MRCOG is an UK exam, so we have to know about the UK thing. So bacteria, the universal screening is not done, and there are certain reasons why the screening is not done. So why? The reasons: many of the women uh, will carry the bacteria, and baby would be born without having any problem. Then screening is usually done in the late pregnancy, and with the screening, whether the baby would be affected or not, we are unable to find. Another important thing, that it is a screening test. If it is done, it is not accurate. So 70 to 25% of the women, when we'll do swab, it will be positive. Uh, but their children will be negative at the time of delivery. So mother is positive, mother has a in the pregnancy positive swab, but the baby is negative. So there is no that much of use. Another situation, 5 to 7% of the women, when the swab is done at usually 35 to 37 weeks of pregnancy, they are negative. The swab is negative, but the baby come out to be positive. So again, because of these issues, they are not doing routine screening, and many babies of the severely infected mother will be born out prematurely from the time of screening. Like usually the screening is done at this time, 35 to 37 weeks of pregnancy, but many babies will be born before that. Apart from this, or if like IAP, like antibiotic prophylaxis intrapartum, if it is given to all of the women who are carrying the GBS infection, then lot more number of the mother and baby will end up getting uh, antibiotic with no good reason. Because of all these suggested reasons, so universal screening is not recommended in UK. So this is important to know, because it may come as one stem of your SBA or your EMQ. Apart from this, there certain risk factors are there for early onset GBS infection. Like what are the risk factors that you should know very clearly? Because in SBAs and EMQs, they are giving twisted scenarios. So there should be complete knowledge about that. So if the previous baby is affected with a GBS disease, second, if like discovery or the identification of GBS carriage is done during pregnancy, either she had any time during pregnancy urine infection, or if the vaginal swab is done for any reason, then the like mother is found to be positive. Then preterm birth, like all preterm birth, then prolonged rupture of membranes, then if the mother has suspected infection, usually chorioamnitis and pyrexia. So these are things that you should know. These are the people whose babies will be at a risk of GBS, early onset GBS infection. So these are the risk factors. Now, like if the testing is done, so the swab can be taken from lower vagina, or it can be done from anorectum. Either two different swabs can be taken from the two different places, or single swab can be taken. If they are taking single swab, then first it will be from vagina, then it will be from anorectum. Then once the swab is collected, it will be placed in a non nutrient transport medium, and the specimen will be transported as early as possible, otherwise it will be refrigerated. And usually the culture will be enriched medium. This much is not that important. The important part is that singles if the single swab is taken, it is first from vagina, then from anorectum. Apart from this, you will find question about this from this line also, that maternal request is not an indication for bacteriological screening for GBS. Like I have seen a question already, that the patient who has got a sister somewhere in any other country, and her screening for GBS is done, and she has come and she wants to ask about that she wants in GBS screening. This kind of question you may get, and the answer will be clear no. That because in the UK, neither universal screening is done, nor screening on the maternal request is done. Okay. Then if the GBS is positive, so what will do, what is the precautions? So we give antibiotic. So what is antibiotic of choice? So antibiotic of choice is for IP is benzyl penicillin injection. And what could be the dose? So it would be 3 grams intravenous benzyl penicillin to be given as early as possible at the onset of labor. Okay, just remember the word onset of the labor. Because in part 2 exam and the questions are coming, that particular word they are looking for, because their options are quite narrow. And it will be continued 1.5 gram for early till delivery. That means once the baby is delivered, you have to stop the injection. It is no more required. Sometimes people do mistake. They get confused with when we are giving that in the preeclampsia, when we are giving magnesium sulfate, it is more than 24 hours also after delivery. So people get, so when they put the answer, they get confused with that. So be very clear, we are giving this for the baby, so that baby should not develop early onset GBS infection. So till the delivery, we are giving antibiotics. This dose you have to remember: 3 gram IV stat, then 1.5 gram for early till delivery. And ideally, the first dose to be given at least 4 hours prior to delivery, because you can understand when you give antibiotic, then it will be like uh, with the metabolism dispersed in the mother metabolism, and the baby will get it. So it will take time. So ideally 4 hours before it has to be given. Now, you will find a lot more number of questions from this slide. For both part 2 and part 3, people will get this question. Part 3 people usually get this question when they are doing labor ward. So some of the scenarios you will find the patient is found GBS positive. Sometimes you will find the patient that the GBS is in the patient in the labor. So this is very important for both people, and the people do make mistake, though this is a very small thing. Now, what will happen if what we read, the treatment of choice was benzyl penicillin. But what if our patient is allergic to penicillin? Now they have put few things here. So if the patient says only she had vomiting, That means that is a non-allergic kind of reaction she had. So penicillin can be given. So only vomiting or any other symptom patient is explaining, but that is not correlating with your anaphylaxis, then you give penicillin injection. Second issue, if the history suggests of allergy is there but it is not severe. For example, there is no anaphylactic symptoms, there is no angioedema, there is no respiratory distress or breathing problem, or no urticaria. That means they may have mild allergy. In that situation, to beta lactams. So in that situation, what they are recommending, cephalosporin. And what is a cephalosporin? That is cefuroxime, 1.5 gram loading dose followed by 750 milligram 8 hourly. So these doses you have to remember, and because it will be asked in both exam 2 and 3. Now if it is a severe allergy, that means patient gives history of edema, respiratory problem, or urticaria, then you can't give any penicillin or penicillin related antibiotics. Then the choice will be vancomycin, and the vancomycin will be every 1 gram, 2 bd has to be given. Now this is the most important part of this guideline in my opinion. So both part 2 and part 3 people should understand what the guideline is saying so that they are able to apply it in the exam. Any of you have got any question here? No questions, okay. Now, like, what if the GBS has been detected in previous pregnancy? We are not talking about this pregnancy. If the woman had previous GBS, so what will be the likelihood the patient will carry GBS this pregnancy? Answer is 50%. This is also an important number from where you can get SPA. Now, if the patient has GBS previous pregnancy, and you will find a scenario like that, the patient has GBS infection previous pregnancy. Now she has come to you, and at 34 weeks or whatever, what are the option you will offer? Now these kind of patients you can offer two options. Either you can offer her prophylaxis, antibiotic prophylaxis when she's in labor intrapartum, or apart from this, another option would be that she should be offered testing in the late pregnancy, and if it is positive, then IAP is done. So this part is important to understand because people do make mistake here. Okay. Now if the testing is done, what is the ideal time? 35 to 37 weeks of the pregnancy, if it is like single pregnancy, and if the patient has previous GBS infection, then at least 3 to 5 weeks prior to anticipated delivery date, the testing should be done. If the patient is carrying two baby, we already know they're at higher risk of preterm, so the testing should be done at 32 to 34 weeks of pregnancy. So these all numbers that are there in this slide is important because you get question from every number. Now few incidences, like if the previous baby is GBS affected, so in the current pregnancy, risk of early onset GBS infection is 1 in 700 to 1 in 800. This is if the previous baby is affected. Second, if the test is done, like we are doing testing here, for any woman, if the test is done and the test is positive, then the risk of GBS infection is 1 in 400. It is 1 in 400. And if the patient has GBS test done that is negative, then the risk of infection will be 1 in 5,000. So these numbers are important and you get question from here. So I'm repeating it again. Previous baby affected, risk is 1 in 700 to 1 in 800. If the mom has GBS, mother has GBS test positive, risk is 1 in 400. If GBS test is negative, risk is 1 in 5,000. All numbers are very important, so you have to learn this because you get a question from here. Now if the previous baby is GBS affected, so like we IAP should be offered in this pregnancy. Okay, now you please understand here in this slide we are discussing that patient in the patient GBS carriage was detected. So mother has GBS carriage. We are not speaking about the baby here. So we are offering two options to mom at this moment of time. But another scenario, previous baby had infection. Then we have got only one option to give. That is, patient should be offered in this pregnancy IAP. So if previous pregnancy mother has in GBS carriage, we are giving two options to the patient, either for IAP or for GBS testing at 35 to 37 weeks. If the baby is positive, previous pregnancy, we are giving only one option in this pregnancy, that is to offer IAP. So this is the difference when mother is carrying GBS previous pregnancy or where baby had GBS previous pregnancy. Very small differences, but yeah, people do make mistake here. Now another this like lot more number of question you will find here. So uh, like if they in the antenatal period, anytime like if they are able to detect GBS, so they will look for like colony count. We know the significant infection we take it when the count is more than 105 CFU per ml. When this much greater than this is the count, you have to remember this number as well, then a patient will require treatment at the time when the diagnosis of GBS is done, and she will require IAP also. Second scenario, GBS has been detected incidentally or by testing, but the patient has got no symptoms at this stage, no urinary symptoms, no any other symptom, and the colony count is less than 105 CFU per ml. In that particular situation, right now at the antenatal, we are not offering any treatment, but yes, because the carriage has come positive, so women would be offered IAP during labor. So from this, from this part of the guideline, you will find lot more number of questions and some. So the key message here: if the patient has symptoms, give treatment now and during labor. If patient is asymptomatic, then give only IAP. Very small difference, but yes, every question count in the exam. Now, you guys can answer this question. 37-year-old woman admitted with a history of GBS carriage. Scan shows placenta previa. She is due for cesarean. So what you should do? Wait and watch. Cesarean category 2. Cesarean category 2 and GBS prophylaxis, or cesarean category 1. So what should be the answer? Anyone can answer. One person has
Ma'am,
to make some. Yes.
2, ma'am. Cesarean,
Very good.
category 2,
Yes.
ma'am.
Yes. So cesarean section category 2 is an answer. But the message that I want to give here is, if the patient is going for cesarean section, in spite of that, the patient is having GBS carriage, so a treatment IAP will not be offered. Okay. So this is the only message I want to give in this question. So antibiotic prophylaxis specific for GBS not required for the woman going for planned section in absence of labor with intact membrane. So in our patient going for placenta previa elective, it is elective cesarean, membranes are intact, though she had GBS, but we are not offering any prophylaxis. Now, labor and GBS. So, method of induction, whatever we want to offer induction, it is not like a change if the patient has GBS or like have no GBS. Membrane sweep can be done. It is not contraindicated in the carriers of GBS. They can go in the birth pool. It is also not contraindicated. Now, this part I have already discussed. The antibiotic prophylaxis is not required when the planned section in absence of labor with intact membrane is done. And another thing, like if the vagina is cleaned before delivery, then like it will reduce the risk of GBS disease. That such evidence is not there. Okay, so that's a few things that updates about the labor and GBS. Now, here is the more confusion that happens. So it is the term labor. Okay. Now, another one question is a 36 weeks pregnant patient has come to you with a leak and history of GBS carriage. What should be the next action plan? Anyone?
Immediate
Immediate
induction of
induction.
labor.
Yes, immediate induction of labor. So the message is the patient who are GBS carrier and if they come with a rupture of membrane or leak, in that situation we will not wait. We will offer her immediate induction of labor and IAP. This is the message only here. Now another question, 38-week pregnant woman with leak but no associated comorbidities, what you will do? Wait and watch, immediate induction, induction to after 24-hour wait, or category 2 cesarean?
Induction of labor after
Ind
24 hours, ma'am.
Yes.
Immediate induction.
No, why immediate induction? Patient has got no GBS here. This is the message I want to give.
Okay. Yes, ma'am.
Okay.
Got it.
There is no
Sorry.
GBS here. Yeah. Therefore, I have made the similar kind of question. This is from my brain. I have put the question to give this message. So if the patient is, at term is coming with a leak and no GBS, in that situation, you know from your NICE guideline, uh, like induction of labor can be offered immediately, or expectant wait and watch can be done up to 24 weeks of pregnancy. Okay. Now same thing again. So if the patient has is known GBS carrier, then immediate IAP and induction of labor as soon as possible. Okay, we don't want to wait because the baby will be infected. Now if the carrier status is unknown or negative, then according to our guideline, we can wait either immediately we can do, or according to the patient wish, we can give expectant management, like labor to start by itself for 24 hours. This is from the NICE guideline, you already know. Now another question, 36 weeks pregnant patient admitted with a leak. She has temperature of 38 and GBS infection was there during pregnancy. What you will do? What is the
Ma'am,
option?
IV amoxicillin 2 gram every 6 hours, ma'am. We should give broad
Yes.
spectrum antibiotic covering GBS also.
Yes. So the answer is amoxicillin 2 gram 6 hourly. So this is also very important slide from where you will find lot of question. It will be used both part 2 and part 3 people. If the patient is coming with pyrexia, then or chorioamnitis is there, then we have to offer broad spectrum antibiotics. Why we are worried? Because this is also number that is important. We know the risk because if the pyrexia is there or chorioamnitis is there, risk of early onset GBS infection is very high. It is 5.3 per thousand. Because of this high risk, and background risk is 0.6 per thousand. So this is the 5.3 per thousand with fever, and this background risk is 0.6 per thousand. So because of this we are worried, so we'll be offering wide spectrum antibiotics that will cover GBS uh, already. So the treatment of choice is this: IV amoxicillin 2 gram every 6 hours, or IV ciprofloxacin 1.5 gram every 6 hourly. Many antibiotic doses I have discussed here, though this guideline is very short, but every line of the guideline is very important, because all of these things you have to remember. Now, another situation when the patient is preterm and we don't know without known GBS colonization what to do. So, if the patient is in a confirmed preterm labor, regardless of GBS carriage, we offer IAP. Okay, so that means, in another terms, all preterm labor patients, when they are in confirmed preterm labor, we have to offer GBS prophylaxis. Why? Again, this is the issue. In preterm, GBS infection risk is 2.3 per thousand, and background, just we read in previous slide, it was zero point 0.6 per thousand. Because of increased risk, we are offering them and GBS prophylaxis. Another important issue is here that like mortality rate from the infection, it is 20-30% in preterm babies as compared to 2-3% at term. So because of these two reasons, we are offering GBS prophylaxis to all women who are in preterm labor. Okay. Now, very important, this people do get confused here. So preterm is there, but it is now the membranes are gone. What you will do? So all preterm prom, they offer IAP. They offer IAP in all preterm prom. Okay, regardless of their GBS prophylaxis. Now there are two things here. If the patient is less than 34 weeks, then usually uh, if the baby is delivered, then perinatal risk would be high as compared to infection. So here they have to take like they have to take individualized approach has to be done here. But if the GBS is there, patient has preterm and prom, and the 34 more than 34 weeks of pregnancy, that time expedition of birth is done if the GBS carrier is there. Okay, so like if the patient is GBS carrier and preterm prom more than 34 weeks, we'll do the expedition of birth. But if it is less than 34 weeks, what we will do? If she is less than 34 weeks, then we know from the NICE guideline, then we offer erythromycin 250 milligram 4 times daily, maximum of 10 days until patient either for 10 days or until the patient is in established labor, whatever whichever is sooner. If in the question sometime you will find the patient is allergic to erythromycin, then next choice you will go to oral penicillin injection, same duration. Okay, so the take home message, all preterm we are offering IAP regardless of GBS carriage. Now if the prom is there, preterm prom, we are offering IAP. Now when the labor has to be started or not, if it is less than 34 weeks, then they have to balance the risk of perinatal risk and preterm delivery. So they are offering erythromycin, as we know from our NICE guideline. But if the patient is more than 34 weeks and GBS carriage, so in this time, if the prom is there, they would expedite the delivery. Okay, so this is important part. People may get confused here. Now, what could be so this is about the mother and what they say about the baby. We should know this, though we are not getting question from this part. So, if the patient how will understand that baby has GBS infection? Slow, abnormal behavior, crying in consolable, a floppy baby, difficulty in feeding and tolerating food, feeds, abnormal temperature or low or high both, rapid breathing, change in the color of skin. So if the babies have a like early onset GBS infection, then the treatment, you will get question from this line. So as treatment would be from penicillin and gentamicin, and it has to be started within 1 hour of decision to treat. So you will get question from here. Okay, so that this part you should remember. Apart from this, baby management, so you get question from this slide also. If the patient is if the term baby and they received IAP more than 4 hours. Previous slide we read that it has to be started at least 4 hours before delivery. If we have started IAP 4 hours before delivery, then baby is fine. There would be routine postnatal care. No special observation is required. But if the patient mother has not received adequate IAP, then observation will be done 0 1 2 hours and too early till 12 hours. So you get question from this line. Apart from this, if the previous baby is effective, so we'll be a little more, you know, uh, like more vigor in our action. So we'll keep baby watch on the baby 1 and 2 hours and too early till delivery. So these two babies they require checks till 12 hours. And if the patient has got enough IAP, then we are not doing any observation. And there is no trouble with the breastfeeding because so breastfeeding is to be encouraged irrespective of GBS status. There's no problem with the breastfeeding. Okay. Now summary. So we are giving GBS prophylaxis. Again, if the previous baby has GBS disease, if we discover GBS carriage during pregnancy, preterm birth, pyrexia, choriomanitis, and the like when the mm, these are any infection features are there. So these are the indications according to guideline for GBS profile for GBS prophylaxis. Okay. Now this is a flow chart, though it summarizes the same thing that we have already done. Now I'll be just summarizing this flow chart because people find it difficult, but it is a summary of whole guideline in one chart. So now, if the previous baby has GBS infection, regardless of anything, we are offering a IAP. So we are doing this. If the preterm labor is there, regardless of GBS carriage, we are offering IAP. So this is quite understandable. Now, if the GBS was in previous pregnancy, this is the mother carries GBS in previous pregnancy, then what we will again give her two options. What I said, that either the mother will offer IAP or will offer testing. So now this part is very clear now. So I was speaking previously also. If the baby is affected, only one option offer IAP. If mother has got carriage, previous pregnancy, then we are offering two options, either IAP or testing. Okay. Now coming to the term baby, if uh, like if it is a prom is there, if the prom is there, then we are offering and the patient is JBS carrier, we are offering immediate induction and IAP. But if there is no GBS carrier, then we will not offer any IAP. Okay. Now, if the patient here in the labor, if the pyrexia is there, we are offering broad spectrum antibiotic. And anytime in the pregnancy, if we are able to find out GBS carriage, we will offer IAP. Now, coming to the antenatal part I already explained. If we find GBS bacteriuria in the pregnancy, that is, count has to be more than 10 uh, into raised to 5 colony count, then we will offer that time antibiotic and also IAP. But if the colony count is less, then we'll offer only IAP. If we are doing cesarean section and the membranes are intact, patient is not in the labor, then we are not offering any antibiotic. So this is just in one chart. Appears to be complicated, but if you do that uh, column by column, then it is quite easy. So I have got few questions. Till now, any one of you have got any question can ask me.
Dr. Priyata, I have one question.
Hmm.
So you mean in case of a full-term baby with BROM,
Hmm.
there will be immediate induction of labor plus antibiotic?
If the
Even if
term yeah, you see, if the term is the now if the term rupture of membrane is there,
yeah,
then if the patient has GBS, then we'll offer immediate induction
okay,
and we offer 24-hour and IAP. But
oh,
if the any other term patient is there, membranes are ruptured, GBS carriage is not there, then
hmm.
according to NICE guideline, we can either start the labor or we can wait for 24 hours.
Okay, okay, thank you.
Okay. Any other question? Okay. Now I have got only 2 3 questions only. So 28 or 8-year-old woman with 38 weeks of pregnancy, she has rupture of membrane, no contractions, clear liquor, but recently discovered for GBS, urinary tract infection. Tracy has been treated. So what you will do? Now the same thing you asked now. This is the same question.
Yeah, correct.
What is the answer? Patient is dumb, prom is there, and GBS is there.
Augmentation of labor and
Aug-
prophylactic IV antibiotics immediately.
Yes. So answer is B. Augmentation of labor and prophylactic antibiotic immediately, and this is the reason. Or any other woman in same scenario, if carrier status is negative or unknown, then we'll wait for 24 hours or we offer immediately. Okay, this is the same thing you were asking. So 33-year old woman in the second delivery, she is known as GBS carrier. She has loading dose 30 minutes. Now how much are we are giving loading dose 4 hours before pregnancy, isn't it? Now baby is born in a good condition. What you will do, you will admit baby, observation for 12 hours, you will do CRP, you will give antibiotics or treat baby as normal. What you will do?
Increased observations for 12 hours. 0, 1, 2, and then 2
Yes,
hourly for 12 hours.
yes, this is the answer. So if the patient has not received adequate IAP, or if previous baby with GBS, these are the two indications. We are keeping the baby under observations at 0, 1, 2 and 12 hourly till 12 hours. Okay. Another question, I think this would be the last. So patient is 36 weeks of pregnancy. She has no symptoms. Urine dipstick is done. Now this is the results they have given. You can look at the results. GBS is positive. What you will do for this woman?
Offer IAP only.
Yes, offer IAP only. Now, why we are offering IAP only? Because the colony count is less than 10 raised to power 5. Okay, so there is no more than so the patient has got no symptoms. So right now we are not giving any treatment. We would be giving her IAP only. Now, last question. So the patient has like 30 weeks pregnant. Midstream urine sample confirms GB bacteria. The colony count is more than 105, and she is sensitive to cephalexin, and she has got symptoms for urinary tract infection. So what you will do?
D, ma'am.
Treatment of
It's
UTI and
Yes,
and then
intrapartum antibiotic prophylaxis. Option D,
yes,
ma'am.
the option D. So as the colony count is more, patient is having symptoms. So we are giving treatment right now, and now she has a risk factor. So we are giving IAP also. That's all I had to say. So thanks for joining. Any one of you have got any question can ask me. Okay, people. So thanks for joining the class.
Thank you,
Bye.
ma'am.
Okay, all the best.
Thank you, ma'am.
Thank you, ma'am.
Yeah, welcome.
thank you.
Welcome.
Thank you, ma'am.